Sensory systems. This is our last chapter. Okay, so special senses include vision, which is sight, olfaction, which is smell, gustation, which is taste, and hearing and equilibrium. Everything about special senses is special, kind of quote unquote. Their receptors are actually cells that act as receptors. Unlike elsewhere in the body, you have these nervous structures, that act as receptors. Sensory neurons are bipolar. So before, with all general body sensation or sensory information is carried on unipolar neurons, these are going to use bipolar neurons. And they have their own area on the cerebral cortex for processing. As you know, we just covered the central nervous system not long ago, and there's different functional areas found on the different lobes of the cerebral cortex. And so they have their own little area. They will not be processed, or this kind of information will not be processed in that somatosensory postcentral gyrus area. Okay, so we'll start with vision. Vision, the receptors are located in the retina. You have accessory structures like the eyebrows and eyelids that protect the eye. The conjunctiva is a mucous membrane that prevents drying out of the eye. It also protects the eye. It doesn't allow certain substances or debris or pollen and things to roll to the back of the eye. The conjunctiva has both a palpebral and an ocular portion. Right, so try to picture this. On about where your eyelashes are, let's say your upper and lower eyelashes, if you lifted up your eyelid, this membrane would run from about where the eyelashes are on the underside of your eyelid, back about 3/4 of the way, and then folds back and now sits on the surface of your eyeball, right, on the sclera, and then inserts around the corneal area, right? So it travels backward and then folds and comes back again toward, anteriorly toward the cornea, right? And that prevents dust and particulate. I'm just trying to think of, debris that's flying in the air, or anything larger than that from rolling to the back of the eye, because at the back of the eye, you have the points where the muscles, extrinsic muscles of the eye are attaching to your eyeball, and you have the optic nerve. So you especially want to protect those areas. So the conjunctiva is this mucous membrane that not only prevents the eye from, drying out, but it protects the back of the eye from other substances getting back there. You have the extrinsic muscles of the eye, I just mentioned, skeletal muscles that move the eyeball, controlled by 3, 4, and 6, oculomotor, trochlear, and abducens nerves. And then we have the lacrimal gland, which is located in the orbit above the lateral end of the eye and secretes lacrimal secretions of what's called tears. A dilute solution, a saline solution containing mucus, antibodies, and antibacterial lysozymes. So the secretions, the tears, create sort of an inhospitable environment for bacteria. It's going to be a little acidic. It's going to have a lot of mucus in it to lube the eye so that, as you open and close the eye, the two conjunctival membranes kind of slide past one another nicely. And it contains antibodies, right? Those are going to be looked at in more detail in AMP2. All right, so the lacrimal glands found at the superolateral aspect of the eye. They have ducts that allow those ducts to pass the tears to the surface of the eyeball, so under the eyelid between those two conjunctival membranes, and it sweeps across the eye and it gets collected in what's called the lacrimal punctum. So if you ever wonder what those little black dots are on your upper and lower eyelid over by your nose, or what's called a medial canthus, is those are there to collect tears, and those tears will then pass through the lacrimal canaliculi, can I lick your eyes, to the lacrimal sacs, and then it goes out the nasal lacrimal duct into the nasal cavity, which is directed toward the back of the nasal cavity. So you swallow some of those secretions. And that's your lacrimal pathway. All right, extrinsic eye muscles. These are six strap-like eye muscles. They originate from the bony orbit and insert on the eye. They kind of travel in different directions, and they enable the eye to follow objects, maintain the overall eyeball shape and help hold it in the orbit. You have four rectus muscles and two oblique muscles. The rectus muscles are found at the quadrant points of the eye, at 12, 6, 3, and 9 on a clock face. And their fibers course straight to the back of the eye, to where the optic nerve is. The oblique muscles course in another direction, in an oblique direction. You have one on the superior hemisphere, one on the inferior hemisphere. So you have a superior and inferior oblique muscles. Their fibers travel in different directions. The rectus muscles, you have a superior, inferior, medial, and lateral. So if we look at a picture of the eye and eye orbit, I call it, we're looking lateral to medial. You can see lateral rectus, see how it's the fibers travel straight to the back of the eye. Superior rectus, inferior rectus. Look at inferior oblique here. It courses in an oblique angle, kind of like a hammock, we call it. And the superior oblique muscle, we can follow the tendon that's originating, inferior to or deep to superior rectus muscle. The tendon courses nasally, kind of medial and anterior, before it passes through this little trochlea. And it's like threading a needle, right? And that's another term for a trochlea here. So that tendon travels through that trochlea, and then the muscle belly, travels on the superior lateral aspect of the orbit of the eye. If we look at it from what's called anterior to posterior, dead on, and this would be a right eye, then you can see your inferior oblique on the bottom. Inferior rectus, medial rectus, is where, the nose side, lateral rectus is your ear side. You have superior rectus on top and superior oblique that passes through that trochlea. So when these contract, they kind of pull the eye in different directions. They don't generally any one work by itself, with maybe the exception somewhat of medial lateral rectus. But as soon as you start using superior rectus and inferior rectus, inferior and superior obliques start to jump in there. But there's ways that you can kind of test the integrity of these muscles and thus their nerve supply when you do a head and neck examination. Okay, so, in the previous chapter, or when we were talking about the peripheral, the previous chapter was peripheral nervous system, and I take that back, it was autonomic nervous system. So 2 chapters ago, peripheral nervous system, we're talking about the different cranial nerves, and we said that for now, 3, 4, and 6 were associated with eye movement. Oculomotor had a lot of other things too. It was the nerve supply to the muscle that elevates the eyelid, called levator palpebrae. It stimulates the ciliary muscles to act on the lens. So ocular motor is going to innervate 4 out of 6 of these muscles, or be the nerve supply to 4 out of 6 muscles. Abducens and trochlear, just 1. Right? So I think it's easier to begin by memorizing the different muscles that attach to the eye, the different rectus muscles, superior oblique and inferior oblique. And once you do that, you go, okay, abducens stimulates lateral rectus, because when lateral rectus contracts, it abducts the eye. So the eyeball, let's say the right lateral rectus is stimulated, the right eye will rotate toward your right ear and look out, to the side. Trochlear nerve stimulates superior oblique, and it was named because the superior oblique muscle passes through that trochlea before it travels on the medial aspect of the eye orbit. So the trochlear nerve innervates superior oblique. Everything else is innervated by oculomotor, and that includes superior, middle, and inferior rectus muscles and inferior oblique. So you can either think of it as oculomotor innervates everything except abducens, lateral rectus, trochlear, superior oblique. Or, there's another way. We always just kind of drew it out. LR6 SO4, all else 3. LR6, lateral rectus cranial nerve 6. SO4, superior oblique cranial nerve 4. All else 6 would be the remaining muscles innervated, all else 3 innervated by oculomotor. So it's LR6, SO4, all else 3. Or you can remember that abducens, stimulates lateral rectus only, trochlear superior oblique only, oculomotor, everything else, whichever method works for you. Or I will say, I'll back up, maybe over this diagram is just write the cranial nerve numbers either next to the name of the muscle or right on the muscle. So here we're superior oblique. You can write trochlear nerve, lateral rectus, abducens nerve, and then oculomotor for everybody else, and put it right on the diagram that we studied. Okay, conjunctivitis is inflammation of the conjunctiva resulting in reddened and irritated eyes. Pink eye is actually a bacterial or a viral infection. They often go hand in hand, but you don't have to have an infection to have inflammation of the eye. You might have just scraping. Sometimes like when you have allergies and your eyes get really red because you're sneezing and you're producing all these tears to wash away all the allergens off the surface of the eye. And so sometimes we can just have inflammation without necessarily having infection. Okay, eyeball structures. So we're going to look at some of the structures of the eye and where they're found in layers of the eye. And we have 3 layers. We see this repeating all over in the body. 3 layers to blood vessels, 3 layers to the heart. We had, essentially 3 layers of the skin. And these layers are called tunics instead of layers. We have a fibrous tunic, vascular tunic, and sensory and neural tunic. So we're going to identify which structures are found on each layer, and then which structures are not necessarily part of any layer, quote unquote, are the lens, the chambers, the fluid-filled chambers of the eye, and the optic nerve. And so the optic nerve leads the posterior aspect of the eye. Okay, so here, this picture, I love this picture because it kind of color codes these different tunics or layers. The white outer layer is the fibrous tunic. It's composed of the sclera, which is the whites of your eyes, and the cornea anteriorly, the clear covering that bows outward. The structures in pink, red represent the vascular tunic, which is mostly choroid, ciliary body anteriorly, and then the iris, which is most anterior. That would be the pigmented portion of the eye. The hole in the iris is called the pupil. And then structures in the yellow layer would be the sensory or neural tunic. The lens is sort of a border between the anterior chamber and posterior chamber, not necessarily part of any tunic at all. But it lets you color code white to red to yellow, fibrous, vascular, and sensory or neural tunics. Okay, so the fibrous tunic, the outermost layer of dense avascular connective tissue, 2 structures, the sclera, which are the whites of your eye, that helps protect the eye, gives the eyeball some shape. It's a surface that those extrinsic muscles can attach to or anchor to. And then the cornea, which is the transparent anterior covering that allows light to enter the eye. That's where you will put your contact lens. The next layer, vascular tunic, in the pinky red layer, choroid, highly vascular pigmented portion. The pigments absorb light, preventing reflection, and helps prevent some of the light photons from bouncing around the eye. It's the majority of the volume of this tunic from the optic nerve coursing anteriorly. The ciliary body contains ciliary muscles, which control the lens shape. There will be little ligaments called suspensory ligaments that attach to the lens. And when the ciliary muscles contract and relax, it acts on the lens to allow it to either flatten or widen and kind of puff up like a nice fluffy pillow. It's also where we have cells that secrete aqueous humor. Humor are the fluids of the eye. Aqueous means it's mostly water. So aqueous humor comes from this structure. The iris is the anterior pigmented portion of the eye. It can constrict and dilate. It can change the pupillary hole size. So it regulates the amount of light entering the eye by controlling the pupil size. That's considered pupillary constriction or dilation. The pupil is the hole in the iris where light enters. Will pass through the pupil to the lens and then ultimately to the retina. The iris has 2 layers of muscles to it. This is how we constrict and dilate. You have the sphincter pupillae, which are the inner circular muscles that contract and pupillary constrict. So the question is, which branch of the ANS would stimulate this reaction? That would be the parasympathetic division. And the dilator pupil are the outer radial muscles. Upon contraction, they stimulate pupillary dilation. They pull open the pupil. And that would be the sympathetic nervous system. Love, love, love this picture because it shows you the 2 different layers of muscles, circular to the interior and radial looking muscles like spokes on a wheel to the outside. Right? When the circular muscles contract, then it causes pupillary constriction. And it says parasympathetic over that. Sympathetic division, those radial muscles will contract and pull open the pupil. That's pupillary dilation. And in the middle, iris has 2 layers of muscles, sphincter and dilator. Okay, then we have the retina, which is composed of 3 layers of cells. So it has, these 3 layers that work together to respond to the light stimuli and then to create action potentials and send it to the occipital lobe to be processed. All right, so we have the photoreceptor cells where transduction of light to graded potentials occurs. It means that these are the cells that act as receptors to these different light photons. Rods respond to dim light abundant on the edges of peripheral vision areas, and the cones respond to bright light, color vision, highest concentration in the acuity area, or it gives you the highest amount of sharpness of vision, and they are found in the highest population in what's called the fovea centralis, because that's our area of visual acuity down on the bottom there. Right. So rods are found more to the peripheral vision areas. Cones respond to light and color, gives you high resolution and sharpness, and they're found in the highest quantity at the fovea centralis. Right, so down on the bottom it says fovea centralis, area of visual acuity, containing cones only. Okay, so next to the photoreceptor cells are the bipolar cells. They receive graded potentials and carry to the ganglion cells. So they're kind of sandwiched in between, and the ganglion cells are on the surface of the retina, closest to what's called the vitreous humor, and they generate and carry action potentials. All those little cell ganglion cells have axons that travel to the optic disc and leave as the optic nerve. Right, the optic disc is where the optic nerve exits the eye, and that is also your blind spot because you lack any photoreceptor cells there. The optic disc is also where we have a blood supply into and out of the eye. So we're going to look at that up in the upper left-hand corner. Here we have a picture of the eye. We're going to magnify that square area there. All right, and so we have the optic nerve in yellow and these red and blue vessels, different arteries and veins that are entering the eye at the same point, where the nerves are exiting because they're carrying impulses away from the eye. We have in white to the outer part of the fibrous tunic is our sclera. Then we have that little red area, rather thin, right? That's going to be the choroid. And then you have the retina, and you can see these 3 layers of cells. They're nuclei that take up a lot of stain. So now over to the left-hand side, we have the first layer that's closest to the choroid. That's your photoreceptor layer. You can see all those nuclei there. Then you have the bipolar cells. And then to the left, you have the ganglion cells. And you can see at the base of that, those little axons all leading away that are going to lead, exit at the optic disc. light photons are going to enter in the eye, shows you the pathway of light in the upper left-hand side. Light will pass through the cornea, through the lens, well, kind of through the pupil. I mean, it's a doorway, and then to the lens, through the fluid found in the back of the eye, and will be directed as best as you can to the central fovea, your area of visual acuity. Stimulate those cells, and impulses travel on the yellow strings there that is the optic nerve, and then travel to the occipital lobe. Okay, the lens is a biconvex structure that can change shape to focus light on the retina. It also divides the eye into anterior and posterior chambers or segments. Anterior to the lens is the anterior chamber, and it's filled with aqueous humor. So aqueous anterior nourishes the lens and cornea, which is replenished through life and produced by the ciliary body. And it has a circulatory pathway, so we're going to look at that in a minute. The posterior chamber, which is the region posterior to the lens, all the way to the retina, so it's a large area, contains vitreous humor and holds the retina in place and is not replenished. It's thicker, more gelatinous, and it helps keep the retina pushed up against the walls. Okay, so here we have the cornea to the anterior aspect. And we have the pupil and then the lens. So from the lens, anterior is aqueous humor. It's produced by the ciliary body here down below, and the black arrows represent the circulatory pathway of this fluid. So it gets produced, it travels anterior to the lens, through the pupil, bathes the back of the cornea, and gets taken up in that little blue passageway. And for some reason, they took the name of that out, but that's called the canal of Schlemm, or the sclerovenous sinus. So similar to cerebrospinal fluid that circulates and has areas in which it's absorbed in these different dural sinuses to the interior of the skull, the bones of the skull, that takes up a lot of the debris and helps clean the cerebrospinal fluid and takes excess fluid, because we're always making more cerebrospinal fluid. Well, aqueous humor travels that way and gets taken up into those sinus cavities. Thus, it helps maintain an appropriate pressure of that aqueous humor to the front of the eye, to the anterior chamber. If there becomes blockage here in that canal of Schlemm, where the black arrows ultimately point to in that little blue passageway or canal, then it can develop into glaucoma. We'll talk about it in a second. From the lens back to the right, to posteriorly, that's where we have vitreous humor. All right, so anterior chamber, posterior chamber, anterior aqueous humor, you need to know that. Posterior chamber, vitreous humor. There we go. All right, so the homeostatic imbalance, glaucoma, condition in which drainage of aqueous humor is blocked, causing fluid to back up and increase pressure within the eye. Pressure may increase to dangerous levels and compress the retina and optic nerve, leading to blindness. Very few early symptoms. You just usually what patients will be complaining about is seeing halos around the lights, especially when you're driving in the dark or, in dim light in a household, and blurred vision. There are tests whenever you get your eyes your vision tested, your visual acuity. When you go to get your eyes, for you're testing your vision, generally using like a Snellen eye chart, they check for glaucoma. And so they do that puff of air into your eye. That's the glaucoma test. Okay, so we need to know the structures in sequence, the visual pathway of light entering into the eye. So the first light photons hit the cornea, and that's where we first refract light. And that means we want to bend the photons. Whenever photons pass through different densities of material, the light photons bend. And if you notice, the cornea bows outwards. So when light photons pass through it, it's going to kind of funnel them toward the pupil. So the cornea to the aqueous humor, to the lens, which also refracts light because it can change how thick or thin it is. Then the light passes to the vitreous humor, to the posterior retina, to those photoreceptors. So it's going to pass through, once it gets to the retina, it's going to pass through the surface layer of cells first before it ever reaches the photoreceptors. We're going to talk about that in just a minute and go through the entire sequence. Okay, well, here it is right now. Through the retina, light changes chemicals in the photopigments, in the rods, and in the cones. Those are our photoreceptor cells, which generate greater potentials. But the impulse travel, therefore, then the impulse travels to the bipolar cells, to the ganglion cells, and the ganglion cells generate that action potential. Right? The ganglion cells become the optic nerve. From there, we have these nerves are going to travel to what's called the optic chiasm, where you have this little cross area. And some of those nerve fibers are going to stay on the same side, which is called being ipsilateral, but some of them will cross to the other side of the brain to be processed. Then the impulse travel through the thalamus, where you sort the stimuli, and then it gets sorted to the occipital lobe. When the light photons enter the eye, it's going to come, this is an example of left to right. So as they pass through the vitreous humor, which would be to the left of these ganglion cells, light photons actually pass through the ganglion cells, then the bipolar cells, and then finally they hit the photoreceptor cells. Photoreceptor cells stimulate the graded potentials here in the bipolar cells, and the bipolar cells stimulate the action potentials in the ganglion cells, and now we have the action potentials ultimately traveling to the occipital lobe. Okay, problems associated with refraction related to eyeball shape. We have myopia, which is nearsightedness, hyperopia, which is farsightedness, and then the astigmatism is unequal curves in different parts of the cornea and or the lens. And they're generally corrected with cylindrically round lenses, or laser procedures. You can do laser procedures. So we're going to look at the shapes of the eye, and this makes a lot of sense. I really find this rather interesting. Because then you can see what kind of lens might be adapted to your particular vision. In myopia, your eyeball is too long, so the focal point where these light photons are going to converge, and then ultimately diverge, is going to be in front of the retina, and it's corrected with a concave lens. Hyperopia, which is farsightedness, the eyeball is too short compared to normal, so the focal point is behind the retina, and it's corrected with a convex lens. So here we're looking at these diagrams. On the top to the left, you have an emmetropic eye, which means it's a normal eye. And the dotted line with red to the right of it, in that same big picture to the left, represents the focal plane. This is where we want all these light photons to ultimately merge and hit together right on that central fovea. All right, so light photons are going to come through the cornea to the lens, and you see how then they get bent, and they should right there, smack dab land on the surface of the retina. All right, so that's the normal eye shape. All right, the dotted line is going to stay the same. All right, a myopic eye below that, and B, you're nearsighted. And so this described it as the eye being longer, than normal. Now the convergence point, see, it hits the same point on the dotted line. What we need to do is spread those light photons apart so that convergence point on the dotted line is going to hit on the retina to the right of it. Hyperopic eye, is farsightedness. That's a shorter than normal eyeball. And again, you can see with the dotted line, vertical dotted line, that the convergence point isn't behind this person's eye. We want to do the opposite of what we did with the myopic eye. We want to converge them even tighter so that that point of convergence is right on the surface of the retina. So when we look at eye B, myopic eye, to the right of it, it shows you the lens, and how you're going to change this. So you're going to have a substance, or something in front of the eye that causes those light photons to diverge a little bit before it ever hits the cornea, and then passes through the lens, and now, boom, it hits on the surface of the eye. And the hyperopic eye C, you're going to do the opposite. You're going to have a lens in front in front of the cornea that causes those light photons to converge kind of prematurely, right? And then they pass through the cornea, the lens, and then land on the surface of the eye. So I think those are interesting to see. Color blindness. We look at this in AMP2, one of the last genetics chapters. Color blindness is when you lack one or more of your cone pigments. for either red, green, or blue. It's inherited as an X-linked condition, so more common in males, but women can get it. And as many as 8 to 10% of males have some form of color blindness. Okay, moving on to the chemical senses of smell and taste. Smell is olfaction and taste is gustation. The complementary senses that let us know whether a substance should be savored or avoided. Chemoreceptors are used in these systems. Chemicals must be dissolved in either of these, in aqueous solution to be picked up by these chemoreceptors, which means that either the substances in the air or the food that you're eating needs to be dissolved in a watery solution. Then your chemoreceptors will have an opportunity, which will be cells, by the way, specialized cells acting as receptors to detect their presence. Smell receptors are excited by chemicals dissolved in nasal fluids, and taste receptors respond to chemicals dissolved in saliva. So the sense of smell, the olfactory foramina, the olfactory epithelium are found in the roof of the nasal cavity. The olfactory nerves, which is cranial nerve 1, right, are going to pass through the olfactory foramina of your ethmoid bone and line the nasal cavity. They contain olfactory sensory neurons, which are bipolar neurons. Location and structure of the olfactory receptors. Well, these odorants are the chemicals or molecules dissolved in aqueous solution. We have tastants, and then we have odorants. So odorants are the chemicals and molecules dissolved in aqueous solution. Olfactory neurons are covered by mucus, which is the solvent, the watery component, for the odorants to dissolve them. And then the receptors can respond to their presence. Olfactory neurons, unlike other neurons, have stem cells that give rise to new neurons every 30 to 60 days. So I think that's rather interesting, and it's good to know. Okay, so here we're looking at, I call like a half-head model. And up on the top, you can see the olfactory bulb. It's sitting, over those olfactory foramina. And if we magnify that little area over to the right, then you see the holes in that bone. That's the ethmoid bone. Those are the olfactory foramina for passage of the olfactory nerves. Over to the left in diagram A, you can see how the nerves extend and line the surface of your nasal cavity. It's the only cranial nerve that's directly connected or exposed to the external environment. Over to the right, you can see how those nerves pass through there. You can see their neuron cell bodies, and you can see how they get exposed into the mucus secretion surface of that nasal cavity. So as you breathe in and out, you can watch the direction of, route of inhaled air into and out of the nose, where it then gives those odorants a chance to get dissolved and captured in the mucus, and then the olfactory sensory neurons can detect their presence. So the pathway, olfactory receptors extend through the olfactory foramina in the ethmoid bone into the nasal cavity. So the olfactory nerves will carry impulses to the bulb, which is, to the right, the bulbs are to the right and left of the crista galli of the ethmoid bone, to the olfactory tracts, in the olfactory tracts to the olfactory area in the temporal lobe, because we have our primary olfactory area there. Remember, it also shares a lot of that information with the limbic system and the hypothalamus. So the limbic system, in our area of emotion and things, this is where we start to connect different scents with different emotions. Gustation is taste. Taste buds contain gustatory cells that act as a receptor. Right, the taste buds are the repeating kind of unit of gustation. Most taste receptors located in the oral cavity, in papilla on the tongue. And the basic taste sensations are sweet, sour, salty, bitter, and umami. Most people have never heard of umami, but that's considered a meaty or savory sensation. The threshold varies, but bitter is the lowest. And that's because most poisons and toxins have a bitter taste to them. So it's kind of built into our design that we respond to those the quickest, so maybe you could spit it out before you swallow. And taste into the molecules dissolved in water and contact the taste bud to generate action potentials. All right, so here we can see there are different areas of the tongue, but here in picture B, we find the large section of a valate papillae. And so we have these crevices where once you chew food, it mixes with saliva, then we have our aqueous solution, and the food can fall into these kind of cryptid areas or papillae. And the receptors, the taste buds and the gustatory cells in those taste buds can detect presence. And you can see how they're kind of like light bluish purplish, and they open up and extend into that fold there. And then at the base of them, you can see these yellow fibers, which would represent the axons of these neurons. We look in the upper right-hand corner, shows you a taste bud sitting in that layer of tissue. It's stratified squamous epithelium layer that it's sitting in. And they'll have these little taste pores, those little openings in which food that you've chewed and is, mixed in saliva can fall through those pores and then stimulate these gustatory cells that are found in the whole taste bud. To me, that taste bud kind of looks like an orange or a grapefruit after you've peeled it, and you can see all the sections. At the base of those cells will be, the axons of these sensory neurons. Now remember, it depends on what area of the tongue or the pharynx, that your taste buds are responding. Let me just say that differently. It depends on where in this pathway that food will follow will determine which cranial nerve, because remember we said 7, 9, and 10, facial, glossopharyngeal, and vagus nerves convey taste, but they convey it from different areas, right? Okay, so we're going to cover that. Uno momento. Down below in the lower right-hand corner, you actually see a slide of a taste bud. I think it's really cool to see those because you can see a little taste pore, and sometimes you can see little hairs kind of extending out into it. Okay, so gustatory pathway. Well, the gustatory receptors in the taste bud, or gustatory receptors in taste buds are found on 3 different cranial nerves, right? We have the facial nerve, which conveys taste from the anterior 2/3 of the tongue. Glossopharyngeal conveys from the posterior 1/3, and vagus from the lower pharynx and epiglottis. 7, 9, and 10. Impulses travel up to the thalamus and get stored to the gustatory center on the insula bone. You lose 80% of your sensation of taste if the olfactory receptors are blocked. I think that's just such an unusual phenomenon because we think that, our ability to sense taste, of course, has to travel to the gustatory center. I mean, we get that. However, we think that, you would think that 80% of the input from these different taste buds would influence, your sensation of taste, but it actually mostly comes from your ability to smell. Right? So once you block the olfactory receptors, let's say if you've ever noticed you have a really bad cold or allergies or something where you're super congested, in your sinuses and things. And it not only can change your voice quality, as we know, because I just did that to myself, I blocked my nose, but that it will also affect your ability to taste food. And when you have colds and flus and really severe allergies, you very difficult frequently to taste what you're eating. And so if you're, maybe if you have something really spicy, that might get through to you, but you often have like a dull taste sensation. And it's not because of the taste buds, it's because of the olfactory receptors are blocked. Okay, hearing and equilibrium. The ear gets divided kind of like the eye into 3 regions: an outer ear, a middle ear, and an inner ear. The outer ear is composed of the pinna and the external auditory meatus or canal and your tympanic membrane. So those 3 structures, boom, outer ear. Middle ear will be on the other side of the tympanic membrane or medial to that. It has an air-filled chamber inside the temporal bone that contains the ear ossicles, malleus, incus, and stapes. Also the eustachian tube and the oval window, and even the round window like that. I'll show you where those are. And then on the other side of these bony structures, then we have the inner ear. These are the fluid-filled chambers that contain receptors for hearing, which is found in the cochlea, and balance in the semicircular canals in the vestibule. Okay, so the outer ear is composed of the pinna, which is also referred to as the auricle, outer elastic cartilage structure that directs sound waves into the external auditory meatus or canal. The external auditory canal, or acoustic meatus or auditory meatus, directs sound waves to the tympanic membrane. On the surface of it, we have cerumen, that's earwax, that helps trap foreign substances so it doesn't hit your tympanic membrane. Your tympanic membrane is very sensitive. The tympanic membrane converts sound waves to mechanical energy. So these sound waves, which you can't see, hits the tympanic membrane and puts it into motion, vibrates it like dropping something invisible that has weight, on a trampoline. All of a sudden the trampoline would start moving. That's what's happening here with the tympanic membrane. It's converting sound waves to mechanical energy. All right, so here we have the auricle or pinna outside. Right? Then you have your external acoustic or auditory meatus or canal, multiple types of terms, depends on the book, and your tympanic membrane. So it also includes the tympanic membrane. Okay, then the middle ear, we go to the other side of the tympanic membrane. You can see these three little bones there, the tube on the bottom, your eustachian tube, and now what's called the pharyngotympanic tube, oval window, round window, middle ear. Then on the other side of this temporal bone, you can see these hoops and that snail shell. That's all inner ear. Okay, so we just did external ear. We're going to do middle ear. These are the ear ossicles. Right? They transmit vibrations from the tympanic membrane to the oval window. The first bone is the malleus, then the incus, and the stapes. The malleus is attached to the eardrum. The incus is the middle bone, and the stapes is attached to the oval window of the vestibule. And it looks kind of like a horse's, like the horse's saddle stirrup, or the stirrup of a horse's saddle, I guess I should say. Show you in a momento. We have the eustachian tube, or the pharyngotympanic tube. Remember, that's one of those elastic cartilage locations. It links the middle ear to the nasopharynx, which is the upper part of the throat. And it equalizes pressure between the atmosphere and the middle ear, so that your tympanic membrane doesn't bow inward or outward because of changes in air pressure. Like if you're flying and you go up in a plane, or if you are scuba diving, the pressure, ambient pressure changes and needs to be balanced between on both sides of that tympanic membrane. Also in the middle ear are oval window and round windows, and I'll show you where they're located in just a second. Okay, so now we're in the middle ear. Right, we have the malleus, incus, stapes. See, it looks like the stirrup on a horse's saddle. If we could tilt back the stapes, we would see another flexible membrane, kind of like the tympanic membrane, called the oval window. And see how the shape of the bottom of that stapes is oval? Thus, the connective tissue layer on the opposite side is going to be that same shape. That way, we take the vibrations from tympanic membrane, malleus, incus, stapes to the oval window, and that puts fluid on the other side in what's called that vestibule, and also into the cochlea into motion. At the end of this cochlea, this snail shell, is the round window that points to it here. And that way, this will allow us to absorb some of the waves, so to speak, of energy that are traveling through that cochlea. So it doesn't kind of go back and forth like hitting a ping pong ball in a box. Below that, we have the pharyngo or the eustachian tube, pharyngotympanic tube, or the eustachian tube. Balances air pressure outside the ear to the middle ear. All right, then the inner ear contains both the semicircular canals and the cochlea, which are composed of where we find mechanoreceptors. We said that mechanoreceptors, are stimulated because something's physically moving. Well, in the semicircular canals, we have fluid-filled cavities with little hairs that extend into the lumen. And as the fluid moves, it moves the hairs. And so that is the physical deformation of something. Those are mechanoreceptors because something physically happening. And in the cochlea, it will be, we have these fluid-filled chambers that look a little bit different, but again, these little hairs are going to be bent, and that generates the action potential in the nerve. Okay, so we have three different major areas. We have the vestibule, which is an egg-shaped bony cavity that connects with the semicircular canals and the cochlea. They contain receptors for static equilibrium. Static equilibrium. The semicircular canals, these are three canals positioned in the three planes of space, and they contain receptors for dynamic equilibrium. And then the cochlea is that snail shell kind of structure, a spiral conical chamber containing the organ of Corti, which is your organ of hearing. Now, this is where we have receptors for hearing, and it ends at the round window. All right, so those are the three major areas. We're going to get a little more detail: vestibule, semicircular canals, and the cochlea. All right, so here we're looking at the inner ear yet now, and let's go down to the oval window. As we said, it looks like a horse's stirrup, and on the other side of that stirrup is this flexible membrane. Right? And so as the vibrations from Malleus and Stapes gets translated to the oval window, it puts fluid on the other side, in the inside of the ear, or the inner ear, into motion. Right? Here we can see the vestibule area, and we have the semicircular canals. Right? We have a utricle in the vestibule, and we have a saccule in the vestibule, but just kind of consider them together as one. As one is fine, excuse me. We have the semicircular canals that detect dynamic equilibrium, and that vestibule area, static equilibrium. At the base of those two structures, you see the yellow fibers there. Those are the vestibular portions of the vestibular cochlear nerve. Below that, we can see the snail shell kind of a structure. That's our cochlea. This is where we're going to find, the organs of hearing. We're going to unroll that structure and kind of take a look at it, because there are three different chambers within each loop, I guess, so to speak, of that snail shell. And at the base of it, we have the cochlear nerve in yellow, the cochlear portion of the vestibular cochlear nerve. Okay, so how does that work? So I've kind of rearranged these over time, so hopefully these make more sense. But the pathway of of sound waves, I should say, are going to travel from the outer part of the ear to the pinna and get funneled down, your ear canal, your external auditory meatus or canal, to your tympanic membrane. And this has a great picture, of the cochlea unrolled, so we can see how these different vestibuli relate to one another. So we're going to kind of come back to this. But what I want you to see is on the other side of this oval window, once this snail shell is unrolled, it's composed of one long hose that has a hairpin turn, and then continues until we get to the round window. So from the oval window to the round window, it's essentially the same tube system with the same type of fluid found there. Because you either have perilymph or endolymph, and I'll just say that this is the perilymph. All right, so where number 3 is, where the first area to receive these sound vibrations from these sound waves, is called the scala vestibuli. And so number 3, the scala vestibuli continues until we get to this hairpin turn called the helicotrema. And now the rest of that hose or tube system is called the scala tympani. And it terminates here at the round window. Between those two is this cochlear duct, or the scala media. And that's where we find our organs of hearing. All right, so, and that's where we actually have endolymph as well. Different type of fluid than what's found in the scala vestibuli and the scala tympani. But you can now see how they're related. And if I roll this back up into a snail shell, or maybe into a jelly roll, because I always think of everything as food, then you see, what you're looking at when you actually see the snail shell. If you unrolled it, you have a scala vestibuli that contains a scala tympani, and sandwiched between them is a scala media, or the cochlear duct. Okay, and so here we have the snail shell. In the upper left-hand corner, we cut into it. You can see how those three chambers are rolled on top of each other. And if we just take one of those and we blow it up into diagram B here, we can see the scala vestibuli to the top, scala tympani to the bottom. Of course, we know that, one continues really as the other. That's why they both have the same kind of fluid called perilymph in both of those. Sandwiched between them is the cochlear duct, or the scala media. Has different fluid. It's called endolymph. But your organ of hearing is here at the bottom of that, the spiral organ of the organ of Corti. It contains hair cells, so go over to the right to diagram C. You have these little hair cells that extend superiorly, and we have this tectorial membrane, which is a rather inflexible ceiling directly above these hair cells. And at the base of the hair cells, you can see the yellow nerve fibers that are going to be the fibers of the cochlear portion of the vestibulocochlear nerve. So you kind of have to go back over to diagram B here to the left-hand side, and you have to picture fluid going into motion in the scala vestibuli, scala tympani, which would ultimately put this basement membrane area, the part at the base of these hair cells of the organ of the Corti, of the organ of Corti, into motion. Right? So they start bobbing up and down, and when they bob up and down, those hairs hit that tectorial membrane and bend the hairs, and that stimulates action potentials on that cochlear nerve. So our auditory pathway includes, starting where sound enters, or gets funneled in really by the pinna to the external auditory canal. They strike the tympanic membrane and cause it to vibrate. Then those vibrations pass through the malleus incus stapes, the ossicles, to the oval window on the vestibule. The vibrations create fluid waves in the cochlea, which pass through the scala vestibuli, scala tympani, puts the hair cells of the organ of Corti into vibration, hits the tectorial membrane. Action potentials are generated in the cochlear nerve, travel to the thalamus, get directed to the auditory cortex on the temporal lobe. And boom. So let's just go back to this picture. Airwaves pass through your external auditory meatus or canal. Remember the pinna is to the outside, and that funnels the sound waves ultimately to your tympanic membrane number 1, through the ear ossicles, malleus incus stapes, to the oval window to the scala vestibuli, around the helicotrema, scala tympani, boom, hits the round window, acts as a shock absorber, but puts this basement membrane, these hair cells of the organ of Corti, found in that middle cochlear duct or scala media, into motion, and that's what triggers the action potentials. So you can read through here in blue. I'm not going to keep reading these over and over again because you're going to get so bored you're going to leave, but it talks about briefly what's happening in there. And then you go, okay, well, now I've stimulated action potentials on the cochlear duct, travel to the thalamus, get sorted to the auditory area. Right. Vibrations here in the lower right, left-hand corner. Here you can see the hair cells of the organ of Corti hitting that tectorial membrane. Right. In blue now we have first order neurons to a second order neuron, traveling up ultimately to the temporal lobe. Passes through the thalamus to the primary auditory area on the temporal lobe. Equilibrium pathways. Well, impulses from the vestibule or the semicircular canals are carried on the vestibular branch of the vestibulocochlear nerve. The brainstem activates reflexes in the body and the extrinsic muscles of the eye. And the cerebellum uses this information also to coordinate skeletal muscle activity and maintain balance. Right. So remember, in the brain stem and We said we had the corpora quadrigemina in the midbrain, those 4 bumps on the posterior aspect below the occipital lobe, but superior to the cerebellum. We had those 4 bumps, the superior colliculi and the inferior colliculi. And the superior colliculi respond to visual reflexes, and the 2 inferior ones are auditory reflexes. But muscles of the head and the eyes are going to respond, and the neck area are going to respond to both visual and auditory reflexes. For instance, and let me just give you an example. Something quickly comes in your peripheral vision, in your right eye. You don't hear anything, all of a sudden there's something like there. You're designed to turn your head that direction. So lateral rectus is going to contract on the right side, so your eye abducts and you look to that direction. The medial rectus in your left eye contracts so that both eyes go to your right side. Right? And you also stimulate muscles to turn your head in that direction. So, because something very quickly coming into your peripheral vision like that could be something that could harm you. Right? So you really want to look and maybe back away. And that's where coordinated skeletal muscle contraction is going to occur as well, because not only are you going to turn your head, you're going to also you're going to shift your body weight a little bit. You might have to do it a lot. So you need to very quickly coordinate, which muscles need to extend, which ones have to flex to kind of protect yourself. Also, these equilibrium pathways, they can be stimulated because you're in an elevator going up and down. You may be driving on the highway and you're making, you're speeding up or slowing down, making a right-hand turn to making a left-hand turn. Those are all different directions of movement that the vestibulocochlear nerve is going to share with the brainstem as well as the cerebellum to control skeletal muscle contraction. So when you make a right-hand turn, you don't fall over to the left-hand side, and into the door. You kind of end up leaning to the right at the same time, and you move with the car. If that makes sense. Okay, different types of deafness. We have conduction deafness and sensory neural deafness. Conduction deafness is a result of damage to structures which conduct sound waves through the tympanic membrane, or maybe degeneration of the ear ossicles. It's really anything that can impair the functioning of any of those structures in the outer and middle ear, or the structures that are considered part of the outer or middle ear. And then when you have some issue there and you're not getting that oval window to be vibrating, then it's considered a conduction deafness. Anything really on the other side of that oval window as part of the inner ear is considered a sensory neural deafness, result of damage to neural conductors like the hair cells, the cochlear nerve, really anywhere along that pathway that the nerve has to travel before it reaches the temporal lobe. So conduction deafness, outer and middle ear structures and their involvement, or sensory neural deafness, inner ear all the way to the temporal lobe. Okay, that takes us to a Kahoot. We don't have a way of playing this, in this method. But if you download this PowerPoint notes and you put it in slideshow mode, if you click on it, you can just, I'm going to do this so you can follow the prompts. It should work for you, so we're going to try it. And you can let me know if it works. It goes to loading, so you go, I can continue as a guest. And you say, got it, and all these different prompts. And then start, and you just put in the pin, and you can play by yourself. Or somebody else can play with you. Let me just move this out of the way and close it. Okay, and that's the end of Special Senses.